respected chairpersons, panelists, friends, colleagues, and national and international faculties. Assalamu alaikum. Now I will present my topic of grade 2021 ACCHA guideline for coronary revascularization and cardiologist perspective of late main and multivessel disease. Actually, I must salute our cardiologists and cardiac surgeons, clinical cardiologists, who are actually developing the treatment facilities whole world. And I must salute our senior colleagues and senior teachers in Bangladesh also, and especially today's guideline, who were involved in this guideline, I must salute. And my topic, you will see the cardiologist perspective of late main and multivessel disease. It is very difficult to say something in favor of interventional cardiologists, especially in favor of this guideline, because this guideline maximum area actually in favor of cabbage. So I'll say something this against this guideline maybe, but not against the guideline. I will say something my interest in this field, and I must respect everybody because our surgeons is here, senior surgeons. So I'll say something everything or my sentence for the people and for the patients, how we can manage the patients. So late main and multivessel is always challenging, especially for managing the patients. So especially heart team management, I will say I already discussed. So lesion severity is very important. We know the coronary physiology, class 1 indication, especially for intermediate lesion, and class 3 also in case sometimes, and I was also 2A lesion, and syntax score very, very important, but it is also discussed, and coronary angiography, especially everybody knows that more than 70% and more than 50% for late main. But in intermediate lesion, we have many things, and sometimes it is very difficult to identify or clarify the length of the lesion and how we target the complex lesion. And it is very difficult sometimes, which is simple and which is complex. I can understand something sometimes actually. So I don't know, during procedure, this planning, this guideline, they have used this newer technology or strategy of PCI, and this type of FFR they have used or not. How many cases they have used this case during this planning this guideline. Now, because few minutes back, or Sufia Madam mentioning that during processing the guideline, sometimes we have assessed the countries or global perspective, sometimes we have no health insurance, or many things we have actually planned and discussed before preparing this guideline. So I will say something because heart team is very important, because especially for late main and multivessel disease, it is very difficult to sometimes say which is better. Even sometimes let the patient choose, because we have no health insurance in our country. And heart team is actually, this concept is come out in the world after the syntax trial, which was introduced or published in 2009. So, and Dr. D.S. Gambhir mentions half an hour back that is syntax trial, also long-term trial. So I will say something. And late main disease and multiple disease, the debatable sometimes PCI, which is better, PCI or cabbage. And this is long-term debate before the publishing of this guideline is still now going on. I hope long after the 10 years or 20 years, 50 years, this debate will be running on. And I think all the heart team is not the same everywhere. Even inter-hospital heart team is not same. Sometimes if in some hospital you can see the clinician take the upper hand. In some hospital the interventional cardiologist take the upper hand, and sometimes the surgeons may take the upper hand. So heart team is always not the same. So, but I must respect everybody who are contributing their thinking this type, improving the patient's quality. And again, I mentioned that when this guideline is prepared, they have mentioned only the patient survival. Already a few minutes back, our senior surgeons already mentioned that the patient survival, but the other things actually they have not discussed or the thinking before the preparing this guideline. So, especially class 1 indication PCI versus CABG in patients with complex disease. Again, I mentioned complex means the thrombotic lesion, severe tortuosity, heavy calcification, complex bifurcation, trifurcation, aortoosteal stenosis. So everything has actually is considered as a complex. But other than these criteria, a lot of patients we have. So how we can deal the patients? In patients who require revascularization for significant late main coronary disease with high complexity, already mentioned, it is recommended choose to CABG over PCI to improve survival. Again, I mentioned to improve survival, but only survival is not our attempt. We have a lot of things to give the patients quality, symptom-free, even less the morbidity, mortality, a lot of things. And class 2A, in patients who require revascularization for multivessel coronary disease with complex or diffuse coronary disease, the synthes score more than 33. It is reasonable to choose CABG for PCI only to confer a survival advantage. We know that CABG is gold standard treatment and PCI is only palliative treatment. But we are doing a lot of PCI in different complex disease, especially multivessel disease PCI. Even in this conference, you will see the lot of topic and even live case, all are doing this type of complex and left main disease with the PCI. But surgeons are always friend, not the foe, but we will discuss how to improve and how to improve this guideline in our regional context. PCI versus CABG in patients with complex disease, especially diabetes, most of the patients have with the diabetes, but all the diabetes is not same. Diabetes multivessel disease, appropriate candidate for CABG, we know, but CABG with Lima to LARD recommended class 1 indication. In this guideline, you will see never single one indication, especially for PCI. All are in favor of CABG maximum. And class 2A indication, 2B indication, PCI can be useful in diabetes who have multivessel CAD and are poor candidates for surgery. And PCI may be considered to reduce major adverse cardiovascular diabetes with late main stenosis and low and intermediate complexity coronary artery disease. A lot of study trials already. You have already Dr. D.S. Gambhir few minutes back mentioned the Syntex trial. This is a good study and long term, and already CABG was superior to PC with lower rates of major adverse cardiovascular events. The benefit was primarily driven by a significant decrease in only repeat revascularization rates, but everything was similar, only for repeat revascularization. So you can do the PCI, the patient maybe need again PCI, that is, but there is no other any mortality or other indicator any difference. So only repeat revascularization. And novel, and you can see the almost no difference was found between CABG and PCI respectively for all cause mortality and stroke. And Excel also very good trial, and so that lot of patients involved in this study. And here synthesis scored less than 32, especially for late main stenosis, lower intermediate. And the primary outcome showed non-inferiority, actually for the composite of death from any cause, stroke and MI at 3 years. At 5 years, no significant difference was seen between PC and CABG for the composite outcome of death, stroke or MI. Revascularization trials of late main disease, CABG versus PCI. Meta-analysis, you have seen 4 clinical trials comparing the PCI versus CABG for late main stenosis, Excel, Novel, Recombat and Syntex, and comparable outcomes for both revascularization strategies in patients with low to intermediate complexity, but more repeat revascularization, again I mentioned after PCI. And another meta-analysis, same the Excel Novel, will see the no significant difference in both composite endpoint of death, stroke and MI. So along this guideline, I am showing this type of meta-analysis for the sharing of knowledge, how we can improve in our regional context for the patients, we can do better management. And ESC 2018 guideline, there is class 1 indication. ESC guideline recommends CABG for late main stenosis for all syntax score group class 1, and PCI for late main stenosis is recommended for patients with a low syntax score less than 22 class 1. But in this guideline, I have again mentioned there is no class 1 indication in this scenario for the late main or multivessel disease. PCI for late main stenosis in patients with an intermediate syntax score can be performed 2A also. So percutaneous coronary intervention with drug-eluting stent versus coronary artery bypass grafting in late main coronary artery disease and individual patient data analysis. The Lancet published this study, and conclusion was that patients undergoing revascularization for late main coronary disease, 5-year mortality does not differ substantially between contemporary PCI and CABG, while key secondary outcomes including spontaneous MI and repeat revascularization are less likely with CABG. You'll see the one is angio. This is 81 years patient. This is primary PCI I've done just last week. If right coronary was totally occluded, and the left side was badly diseased. Actually, I did the primary PCI that patient, but my question actually after the primary PCI, how will manage the patients with multiple disease with the left side? So there may be heart team also there also, and heart team also recommend maybe medical treatment because patient is 81 years, how maybe surgery, but most of the time the heart team will decide and let the patient choose again, because patient 81 years, the after chest pain when when his chest pain disappear, now patient was very good. How will we will manage the patient in next time? So 81 years, I will share the knowledge with my learned audience. So STEMI we'll see STEMI with multivessel disease, especially by patients without significant comorbidities with large non-infarct vessels. This is very, very important, especially in this scenario. Suppose in hemodynamically stable patients with STEMI in this scenario, multivessel disease after successful primary PCI in this case, stage PCI of a significant non-infarct artery stenosis is recommended class 1, and low complexity multivessel disease PCI of a non-infarct artery stenosis may be considered at time of primary PCI to reduce cardiac events, class 2B. And in STEMI, in selected patients with complex multivessel non-infarct artery disease after successful primary PCI, elective CABG is reasonable. And this is class 3 harmful. I will not discuss, complicated by cardiogenic shock, so I will not discuss in here. So this is primary PCI, these patients, right here, and next discussing already. Now non-STMI, this is very conflicting and sometimes very difficult to identify the culprit lesion, especially recommended timing of invasive strategy in non-ST elevation of SCS, and immediate invasive strategy may be done, early invasive strategy within 24 hours, class 2A, invasive strategy with intent to perform revascularization before hospital discharge, initially established patient. So actually revascularization in this context of non-ST SCS should consider clinical stability, risk of recurrent events, coronary anatomy, and degree of myocardial risk, but sometimes it is very difficult to identify the culprit vessel as ST elevation MI, we can identify the culprit lesion, but sometimes it is difficult to identify in this scenario. Especially, should we perform a complete revascularization in patients presenting with non-ST SCS and multivessel disease? So in high-risk patients presenting with non-ST SCS, coronary angiography should be performed as soon as possible within 24 hours from hospital admission, and already it is reasonable to consider physiology-guided revascularization of non-culprit lesion in patients with non-ST SCS with multivessel disease. This is heart, not this guideline. And the stable ischemic heart is very, very conflicting. I know yesterday our Fazila madam also mentioned this when she is presenting his case. So this is another conflicting actually, especially in guideline. This is very, very important. I am showing the guideline, this 2021 guideline. So class 1 indication, you will see if refractory angina, anatomic indication and indication of improvement, you will see the guideline class 1 indication, and in the right side you said if no refractory angina. So I'll mention only same place. this area, cabbage and PCI, will see. Especially for patients with low heart failure, low ejection fraction, we can recognize the cabbage, but our few cardiac surgeons actually do this patient's surgery if EF is less than 35. And heart team sometimes very difficult to say which is better. Sometimes they send the patient only medical management. So guideline therapy we can discuss, and our time is actually very little, so I will skip some. One was single vessel again, according to proximal LAD. Already class 3 indication, I will not mention. And revascular approach to reduce cardiovascular events, stable coronary heart disease. To be, and I will say post-CABG patients. We'll see the post-CABG patient, especially, sorry, 2 slides I will say. This is post-CABG patient. So, you see the right side only we can do something. Otherwise, we have nothing, patient has symptom. So, what should we do according to guideline? So, I will discuss, and time is very limited. Again, we will see the one study, one case says coronary angiogram, inappropriate graft replacement. Just within the stent, over the stent, the graft was actually implanted, but we know our surgeons, few minutes back, he mentioned that should be grafted in the healthy area. So again, I mentioned that PCA versus CABG is still now a good debate, and always we know surgery is a gold standard treatment, but sometimes we do PCA also. We are doing this, but there is no class 1 indication for PCI in this guideline. So moderator benefit we should consider quality of life, milestone of percutaneous technology development, lack of trial with newer PCA technology outcome, or need more trial to make a conclusion. Assessment of ischemic burden is very important. It is highly variable always. So surgical audit should be done, but in our country not everywhere. We have never seen this any surgical audit, and surgical risk calculation should be done also. And 2 goals of therapy, especially that should be considered, already mentioned, and age of the patient should be considered, and use of graft in CABG, that is very important, so arterial, venous, and newer imaging. So that is not discussed in this guideline. For that reason, I am actually incorporate this few sentence. So decision should be individualized in some cases. So always let the patient choose again. A lot of unanswered actually question and answered in this guideline. So due to time, I will not discuss, but a lot in this guideline, lot of things that is confirmed, and some unanswered question mark they have mentioned in this guideline. Due to time, I am skipping all the things. And yes, the guideline, they have mentioned lot of things in this class 1 indication you have mentioned, but in this guideline there is no class 1 indication in favoring PCI.
Your time is over.
Yes, yes. Now last slide. One size does not fit all. All nuts are not same. All eggplants are not same. All diabetes mellitus, multivessel or Lettman, all cabbage or PCI are not same. So lot of debate is still now going on, cabbage versus PCI, end of the debate. This is New England Journal in 2020, and the treatment of Lettman disease, let the patient choose. This is 2020-21. So still now debate going on after publishing this guideline also. So thank you. This is our dream. So this bridge we can use to fill up the gap, the real scenario with the guideline. So we hope we can conclude the session, especially in our regional context. We can publish the guideline for our patients, and the newer guideline should be corrected, especially our patient should be patient friendly and cardiologist friendly. Thank you for patient sharing.